Our next speaker, it's really great pleasure to introduce Travis Osterman. Travis is a medical oncologist at Vanderbilt. He has many roles, but he himself said that he would like to be announced that he serves as the chair of MCODE Executive Committee and focuses on cancer data standards. Travis.
Good morning, everyone. Thank you for the opportunity to come today and talk about ensuring integrated diagnostics to facilitate oncology care. I want to thank the Academies for hosting this and to the co-chairs, Kojo and Hedvig, for that great introduction. Here are my disclosures. So I think of integrated diagnostics as a pipeline, and this allows us, I think, at least to have a framework to set an evaluation. As Hedvig said, one of my main interests is cancer data standards. So I'm going to look at this from a data standards standpoint. We've already heard that integrated diagnostics is an interdisciplinary field, and one of the big challenges is the interoperability. That's kind of the bolting of all of these pipes together. That's where I live day in and day out, and so I'm going to focus largely on that piece today. This is multidisciplinary, and it's also temporal in nature because we want to have that patient journey also be documented throughout, focusing on interoperability. So on that interoperability side and data standards side, I'm going to talk in 5 different areas. So we're going to talk a little bit about surgical oncology and the opportunity there with synoptic operative reports. We'll talk about the current state of clinical staging, genomic reporting, and then opportunities around recording outcomes in clinical trials. As we look at each of these, I just want to plant the seed. From my standpoint, 3 key questions exist as we think about all of these groups and the handoffs that exist to support integrated diagnostics. Do we have a data standard? So we should always be looking to identify gaps in data standards. Sometimes the issue with our pipeline is the pipeline stops and it ends in a bucket, and then someone has to carry that bucket to someone else's pipeline. And that bucket can be clinical notes, it can be any other manual process. So we need to advocate for data standards where there are gaps. Is the standard being adopted? And so I think we've all heard the toothbrushes analogy here. Data standards are like toothbrushes that we all advocate to use them, and we only want to use our own. Data standards only work when we use them. And then our clinical workflow is aligned, and this goes really with the second one, that if our clinicians and patients are in a position where they can't implement the standard, if we're too complex in the implementation, then that standard is going to fail. It's not going to be adopted, and we're back at square one. So that's the framework that I'm approaching this with. I'm going to start with synoptic operative reports. I've got a lot of pathology colleagues here in the audience that have been using synoptic reports for a very long time now. We're now, for the first year, we're in 2023, so this is now rolled out by the American College of Surgeons, the Commission on Cancer, starting to require some specific oncologic surgeries to incorporate some data elements in a structured field in that operative note. If you heard a lot of conditionals in that statement, it was on purpose, and that's really in recognition to all of our pathology colleagues who've been filling out fully fledged synoptic reports for, again, a long time. I think this is a step in the right direction. The ACS looked and said, we don't have a data standard in this space. And so the surgeons essentially had a bucket, and they dumped that bucket into the pipeline, and someone else had to pick it up. So whether that was pathology or someone else had to take what was in that unstructured operative note and structure that in a way that fills the rest of the integrated diagnostics pipeline. So we really just want to highlight this. And again, I think many of us are at certainly academic cancer centers that are accredited by the COC are in the midst of implementing these standards now. I think we all expect this to continue to roll out throughout oncologic surgeries. And I would expect to see this probably in non-oncologic surgeries to some degree as well going forward. So keep your eye on this evolving data standard. But I think this has been a really big breakthrough for the field. Again, going back to my other 2 questions, is it being adopted? Well, right now we're kind of forced to adopt it if you're accredited by COC. So that's not necessarily a negative. I think a lot of these initiatives do have to come from the top. And so this is certainly one pathway towards adoption. And how does it fit into clinical workflows? I think this is to be determined. This is one of the big challenges. I think we're going to find this out very soon. We don't have a best practice right now for how to integrate this with our surgery teams. Again, we have surgeons that are typing their notes. We have surgeons that are dictating. We have surgeons that are highly reliant on their trainees to provide parts of this. And we're trying to figure out how to implement this, not just at our institution, but I would argue nationally. So staging, so again, we've talked about having synoptic operative reports in pathology for a while, and certainly pathologic staging is synoptic and structured. For those of you that may not be aware, clinical staging is horribly behind, and so this is a study from the University of Wisconsin showing that their baseline staging, structured staging for clinical cases was around 20% before they started this initiative. I would say that that's even optimistic. Many centers are well below that. Why is structured staging important? Well, not only for quality measures, but if you want to set off the rest of, again, that integrated diagnostics chain, you want to be able to recommend treatments, et cetera, and you need to have that stage available to, again, hand off to the next section of the pipeline. So did we have a standard here? Again, like toothbrushes, we have several staging standards depending on the underlying disease. I would argue that that's fine. We can adapt to that. Does it fit the workflow? And here's our challenge, because if you ask my medical oncology colleagues, they would say, absolutely, I clinical stage. If you look in any single one of my notes, that stage is right there. It's usually the first line of my assessment and plan, and you have a bucket, because someone else has to pick up that bucket and dump it into someone's pipeline. And so the challenge here is we have a way to do this. We have a place in the medical record, I would argue, for most of our medical records that we can enter that stage. It's just not in the note. It's a separate form that the medical oncologist or surgical oncologist has to go to and fill out that form. And they don't see many don't see the direct benefit to either them or their patients. And so that goes to the third question, does it fit in the workflow? So we have a standard. We have a place to put it, and it's not fitting in the workflow. And that's what we see. We see adoption rates that are sub 20% for clinical staging and for people that do research in electronic health records. I would argue in the oncology space, this is the bane of many of our existence, because if you try to separate out early stage breast cancer, finding those early stage patients by stage is really challenging. And so you have to find surrogates for that. So the University of Wisconsin said, well, we'll fix the workflow by forcing oncologists to fill it out before they can sign their clinic visit. That's the solution. Again, this is a workflow problem, and I put this up here largely to show that it's a workflow problem, and so we can do better. So I think one of the places we have to figure out is how we can integrate things like structured staging into the workflows of the oncologist and others that are taking care of patients. And I hope you just take that seed going forward. As we hear about other implementations, you can have any grand idea of all of the structured data that you would like to collect to support a grandiose pipeline. But please, at the end of the day, for those of us still seeing patients, make it something that we can actually work into our workflows as we continue to support patient care. Forcing people to do this before they sign their visit works. 90% compliance now. I openly joke with my colleagues at the University of Wisconsin about this when we're in meetings together, and so this is all good fun. Next, we'll talk a little bit about genomics. So this is a passion of mine, and I think it's a passion for many of us in the room. And I think that, again, many of us have probably lived through kind of all generations of this, where genomic testing was single genes in-house potentially, and then we were making decisions about how much of this was going to be in-house and how much of this was going to be sent out. And I think for most institutions, they slowly migrated towards sending a lot of this out. And then we started getting faxes back. So we gave up all of the structured data and instead got not even PDFs, but really bad facsimiles where sometimes it was really hard to interpret, the little changes that are actually key to understanding the report. And then we maybe upgraded to PDFs. And I would say standard today for many institutions is having a set of portals that each oncologist manages their login to, and that's where the information largely flows between that outside vendor and the ordering oncologist. And the challenge there now is a brave new world where now you don't even have that fax in the medical record sometimes because it lives in a vendor portal and it doesn't find its way back into the medical record. And so in some ways that's even worse than a fax because that's a bucket that we don't even know where the bucket is. But again, we've been making progress here. And so in 2019, we had the first instance of an institution that was receiving structured genomic data using the, at that time, relatively new HL7 clinical genomics data standard. That was, I think, initially presented by Dr. Levy, who is in the audience here at the EPIC UGM 2019. Rush University at that time was the first institution to implement this. And to date, we now have 49 institutions, to my knowledge, that are receiving structured genomic data from vendors. This continues to be exponentially adopted. So why was this a win? Why did this work where others have seemed to fail? Well, we needed a data standard. And up until around 2018, 2019, we really didn't have a data standard. And so through HL7, a group came together to answer the question of how can we structure the transport of genetic data, not just for cancer-based testing, for somatic testing, but for germline testing and pharmacogenomic testing. That's an ambitious goal, but the work group was able to agree on that standard, and then we had adoption by a number of reference laboratories because they were wrestling with the same problem. Many of them had proprietary formats that if you were an academic institution and happened to have a large health IT group, you could probably digest that and figure out a way to store that somewhere. Not necessarily integrated in the record, but you could store that. That's what we did at Vanderbilt for a number of years. But now we see that we have adoption of this standard by health record vendors. We have adoption of this standard by healthcare systems and, importantly, by reference laboratories. And so this is a big win. So we've really seen exponential adoption. So we needed a data standard. We got a data standard. We had people that were implementing it. And then where does it fit into the oncologist workflow? And this is my favorite part. We made it easy to do the right thing. So I order this now like I order any other test. It's just like ordering a CBC in my system. And it comes back to me just like a CBC, which is fantastic. And then in the background, we can do all of the other population health, clinical decision support, fire this off to recommend clinical trials and everything else in the pipeline. And I would argue that that's really what we need because I don't know what the next thing in the pipeline is going to be, but the end at least is interoperable. So we can bolt on whatever else we need after that. And this is just a list of at least some of the organizations. It's hard to keep this slide updated now, which is like the best problem to have, that are currently receiving structured genomic data by HL7. So I think those, at least for me, are some of the biggest improvements in the pipeline nationally over the last few years, at least. Now, that's not to say that we don't have tremendous opportunities, and we're going to hear about lots of great implementations in coming sessions, but I want to highlight a couple of opportunities I think that are important, especially if we're ambitious and think all the way down to the end of that diagnostic pipeline, where we're thinking about recommending treatments and assessing outcomes. So I want to start with disease status, and so I chair the MCODE Executive Committee. MCODE is the Minimal Common Oncology Data Elements. It's an interoperable data standard that lives on top of FHIR. So it means it allows us to understand and describe the cancer patient's journey across that cancer care continuum. This was initially released in 2019, and today we are currently on Standard for Trial Use version 2, and we're about to ballot for version 3. But I want to highlight this one specific piece here. Within MCODE, we rely largely on other data standards, so we don't want to reinvent data standards that already exist, but some are very specific to the cancer space. In this concept of disease status, and I've included the definition in the inset here, so a clinician's qualitative judgment on the current trend of the cancer, whether it's stable, worsening, et cetera. And so if we hear many of us are going to think RECIST, and RECIST is certainly one way that you can assess disease status. I would argue that there are others. This was a gap in data standards. So this was a space where when we were creating MCODE, we didn't see that there was a data standard that really fit all of the cases. And so we proposed a value set in this space. One of the challenges has been adoption, and it's really hard actually to pull these data out of electronic health records today. And the reason is a couple of fold, but it really also goes back to that third point, which is workflow. And so this is this is a concept that has a very temporal nature, meaning that really this disease status is assessed every interaction with the patient. And that doesn't have a great spot to capture unless you talk to oncologists, which again would say, well, it's in my note. And that's another one of our challenges. So we've been working with healthcare record vendors to try and improve our ability to capture disease status, for instance. But I would argue we still have a lot of space in this area to go. Next is clinical trial matching. So we appreciate clinicaltrials.gov as a site for aggregating clinical trials, and there's an API where you can get structured information about those trials. And this is the structured information you get about the inclusion criteria for that clinical trial, which is not structured really. It's structured for a human. It's a bucket. So it's something that we can read, and if you talk to my research nurses, they would say we kind of read, but it's still ambiguous. And at the end of the day, I would advocate that we really need to structure our inclusion-exclusion criteria so that we can, again, connect that with pipelines to recommend treatment. And the final one that I'll highlight is protocol interoperability. At the end of the day, we are spending a lot of time rebuilding the same clinical trial protocols across institutions, and that's really the end of the pipeline. If we're talking about recommending trials, we would like to get these trials spun up, and so I just wanted to highlight this consortium, the Clinical Trials Rapid Activation Consortium, or CTRAC. This is a project that's run by Dr. James Yao from MD Anderson. And again, taking on the ambitious task of can we make trial protocols interoperable so that we can install them at multiple institutions without having to reinvent that work. Again, it shouldn't be a bucket that we hand off to the cancer center. This should be something that we can share, and that would be the end of the pipeline. So in summary, we've made remarkable progress towards interoperability. We continue to have gaps, especially around clinical trials, both in the matching process and inclusion-exclusion criteria and our ability to structure those protocols. And we need to identify gaps in data standards and advocate to fill those gaps where necessary. And maybe the most important thing, we can't implement these systems in isolation. We need to consider workflows. So with that, I think we've got a chance for us to get together as a panel, and we'll do some questions and discussion.